So I want to start off today with talking about why it's so important for you to raise awareness around colon cancer.
Yeah, so colon cancer is one of those things that it is such a common cancer, unfortunately, and it's rising in incidence. And so it's very awkward to talk about sometimes. And I think particularly, those of us that may not talk a lot about our bowels or about any blood in the stool, is a hard conversation to have with your doctor. And so one of the reasons why I love doing these interviews and I really appreciate the opportunity to be here is because it's important to talk about these things, to know what's normal and what's not, and how we can screen for colon cancer, survey for colon cancer, and decrease the incidence over time.
Tell us a little bit about what colon cancer is and what people need to be on the lookout for.
Yeah, so colon cancer is what we call a gland forming cancer, an adenocarcinoma. We say that it starts out as polyps in the colon. And so that's really what we're doing with colonoscopies is we're looking for these little precancerous growths. We call them adenomas, but really that's just fancy for precancerous growth. And so about 40% of people will have these precancerous growths in their colon. And we say that the incidence of that starts going up around the time when you hit 45. And so that's why we say that everyone in the community, even if they have no symptoms, even if they have no family history, needs to start colon cancer screening with a colonoscopy starting at age 45.
And so, how likely is it that these growths will become cancerous?
That's a great question. And I think that the specific answer of, well, if I have a little tiny precancerous growth, what are the odds that becomes a cancer? We don't really know that because we don't leave them in place. Whenever we find them on colonoscopy, we take them out. What we do know that is that if you have these polyps or these precancerous growths on colonoscopy, you are at a higher chance to get colon cancer down the road. And so if we find them after we take them out, we change the frequency with which we do colonoscopies. So for people at average risk, so people that don't have a family history, people that aren't having bleeding, people that don't have anything like Crohn's disease, ulcerative colitis, or some other familial conditions, for those folks, we say every 10 years is totally fine, starting at age 45, to get your colonoscopy to make sure that no polyps have grown. For people that have more than that, for people that have polyps or for people that are at higher risk, then we recommend more frequent surveillance, either at 1 year, 3 years, or 5 years, depending on the number of polyps and the type of condition that you have. And so it's one of those things that it is so hard to tell people, unfortunately, polyps are asymptomatic. They don't cause bleeding most of the time. They don't cause pain. They don't cause narrowing of stool. But it's really important to get just what your doctor recommends in terms of getting a colonoscopy at the right time.
And so, for some, a colonoscopy could be kind of scary and they don't know what to expect. And they might not hear the best things around that experience. So, could you kind of explain what people should be prepared for and why it's still important, even if it's not the most comfortable thing to do it?
That is such a great question. And so in general, the way that we do colonoscopies is we've got to see the lining of the colon. And so to do that, we make you poop a bunch in order to be able to see the lining. And so that's really where a lot of people's discomfort and people's kind of dread of the procedure comes from, is getting that colon wall clean. And I am here to tell you, it is not fun. Like, if anybody tells you prepping for a colonoscopy is great, they're wrong. But it's all about kind of the risk and benefit of what we do. And colonoscopy is one of those procedures that has such a huge benefit and such a little risk that it is highly recommended. So, in terms of what it actually looks like, what we generally say is you either meet your doctor that's going to be doing the colonoscopy or talk with their office. And if you're fairly low risk, then we usually will do that over the phone. What we have you do is we call in what we call a colon prep to the pharmacy, or take just a generic that we can talk about later on, mixed with some kind of colorless Gatorade usually. People take that the day before the procedure and poop a lot. We want them to have diarrhea the day before the procedure. The day of the procedure, they come in and they have had nothing to eat since midnight that night. They come in, they meet the team that will be doing the colonoscopy. They are wheeled back to the room. They go completely to sleep for the most part. We use a drug called propofol to help make sure that people are very comfortable during this procedure, although they do not have a tube down the throat, nor are they paralyzed. What I do then is I do a rectal exam when they're completely asleep, and then I pass a colonoscope up from the anus all the way to the very top of the colon, which is called the cecum. Most of the time, we also identify where the appendix base is in the cecum. And we try to go into the small bowel as well to make sure that we know exactly where we are and to make sure that that is normal tissue as well. We then pull the scope out, all the while looking at the lining or the mucosa of the colon. And if we find polyps at that time, we take them out if we possibly can. And we do that through the scope. There's not any incisions on the belly, there's no pain with this. The procedure usually takes somewhere between about 20 to 40 minutes, depending on the complexity of it and how many polyps we remove. It is not a risk-free procedure. And I always tell people, you need to talk about the risks and benefits of what we're doing. For some people, like people that are very frail, people that are demented or not, not themselves, if they are stuck in a bed, if they're living in a nursing home, a lot of times those folks don't benefit from colonoscopy as they get older. But for people that are healthy and living independently and driving and doing all the things, colonoscopies are a very benefit high procedure compared to the risk. But the risks that we talk that are the scary things that people may have to be concerned about 1 to 2% of people will have bleeding after colonoscopies. And usually it's just a couple of drops of blood, nothing to be worried about. But very rarely there can be life threatening bleeding that requires blood transfusion or even going back in with colonoscopy or rarely surgery to fix that bleeding. And that's usually after we take out big polyps, although it can be with a routine colonoscopy as well. The other really scary thing that can happen is something called a perforation, where the scope goes through the side of the colon. And that is vanishingly rare, like way less than 1 in 5,000 times. But man, when it happens, it is a terrible thing because sometimes those people need surgery. At the very least, they need antibiotics and admission. And that can be awful whenever you're talking about a prophylactic procedure that people weren't expecting to have complications from. There are also things that can happen with the anesthesia that they have, the propofol. Places have a separate person that monitors you while you're asleep to try to prevent those complications.
So, how often, let's talk about how often someone should be getting a colonoscopy, depending on their family history or their medical history.
Yeah, so we group people into either high risk or average risk in terms of their risk of colon cancer. And based on that risk stratification, that's how we decide how frequently they need colonoscopies. For people that are at average risk, so they have no family history, they have no familial conditions that could be linked with colon cancer, and they don't personally have conditions like inflammatory bowel disease, then those people start at the age of 45. And so the kind of codicil to that, the exception I make is whenever people come in and tell me, "Oh, I'm having bright red I'm having some bleeding whenever I have bowel movements," or "I have normal bowel movements, and then 2 months ago they started getting really skinny and narrow like a ribbon," or "I have really bad belly pain and a lot of weight loss." Those are people that fall outside of those average risk colon cancer screenings. And a lot of times we recommend that they get colonoscopies before the age of 45, depending on the symptoms that they have. For people that are at average risk, so people that don't have those problems and no family history or personal history of colitis, then those folks 45, and then every 10 years after until they reach about 75. And once they reach 75, it really is a personalized discussion with your doctor about if you will benefit from a colonoscopy or if the risks get higher than the benefit at that point.
So, once you get to a certain age, is it because it's, not something that'll be helpful, or is it just not worth it to go through that way?
A little bit of both. I always say it's a little bit of a mixed blessing whenever you're told you don't need screening anymore, because part of it is, hooray, I don't have to do a colonoscopy prep. But part of it is also, oh, well, if I'm not going to benefit, then that means I, have a shorter lifespan than I used to. We say that those people that are really frail, those people that have a lot of bad cardiac problems, the chance that they have a risk or a complication with either the procedure or the anesthesia goes up. And so that's why we say they may not benefit from it. Colon cancer in general, and there are definitely exceptions to this, but colon cancer in general is a very slow growing tumor. We say that in general, it takes about, sorry, I've got printer going on here. In general, we say that the doubling time of polyps, so the time it takes for a polyp to go from this big to this big, is about 2 years. And so it is a fairly slow growing thing. For people that have more aggressive forms of this, people that are diagnosed younger or with rectal cancer, that is not always true. But in general, we say it's a significant chunk of time from when colon cancers grow up from polyps when they're precancerous to cancers when they're cancerous. And so we have kind of time to do that. And for someone that's 75, we say that the risk that they have a polyp that we didn't find that could grow up into a cancer over their remaining life is very small.
Just so I can understand correctly, is there a difference between colon cancer, colorectal cancer, and rectal cancer?
That's a great question. So colorectal cancer is both of them together. Colon cancer is just the kind of abdominal portion of the colon, and then the rectum is still part of the colon, but it's in the pelvis. And so we say that all of the cancers are the same. So colorectal cancer is all that gland forming or adenocarcinoma. We say that rectal cancer not only is treated a little bit differently, but it is a little bit more aggressive as well. And so rectal cancer, which actually, unfortunately, it represents like 50% of all of the cancers that are diagnosed in people younger than 50. It's only about 20% of those of cancers that are diagnosed over the age of 50. But we say that rectal cancer is treated a significant way different than colon cancer. So that's why we distinguish those two. But in answer to your question, it's all the same kind of cancer. There are just slightly different treatments for rectal cancer, and there's a different prognosis for rectal cancer.
We can move past, the colonoscopy, the coming to you, getting the information about everything prior. But what happens for someone to meet you, the surgeon? Like, how do we get to that point, and what should they expect after maybe being diagnosed with colorectal cancer?
Yeah, so colorectal cancer is a diagnosis that is usually made on colonoscopy, although sometimes it can be made on CT scans. A lot of colorectal cancer or a lot of colorectal surgeons like myself do colonoscopies, often will do screening colonoscopies. And so sometimes people meet me in that way. But whenever people are diagnosed with colorectal cancer, either by CT scan or colonoscopy, the first step is to figure out exactly if this is spread or if it's localized. Whether it's colon or rectal cancer, that is always the first step. And we do that by getting a couple of studies. One of them is a CT scan of the chest, abdomen, and pelvis. The two most common places that colorectal cancer spreads is to the liver and to the lungs. And so those are specifically the places that we're looking at. We also get a lab test called a CEA that is really helpful more as a surveillance measure. And so once we treat the colorectal cancer, we get another CEA and see how that number is doing. And over time, we say that if that CEA goes the bad way, which is up, then we need to increase our surveillance and do some other things to make sure that there's no return of the cancer. That is always the first step whenever you're dealing with a type of cancer, is to figure out if it's localized or if it's spread, also called metastatic. Once we figure out that it is localized, then you're in the right place. Surgery is the primary treatment for colon cancer that has not spread. A lot of the treatment that we do depends on exactly the location within the colon versus the rectum, because the colon is primarily a surgical treatment, whereas the rectum, we use three different kinds of treatment. We use chemotherapy, radiation, and surgery. And the combination of those three is what gets us to the cure, which is the goal of all colorectal cancer.
Getting a diagnosis of colorectal cancer, what do you tell people? I know it depends on their situation and the stages, but is this something that, is detrimental? Is it something that they can be hopeful about?
There is always room for hope with these things. Like we talked about, colorectal cancer in general is pretty slow growing. And oftentimes for people with colon cancer, we catch it really early, like especially if people are getting kind of colonoscopies and we find, let's say, a cancer within a polyp. Oftentimes, just doing a polyp removal with colonoscopy is the cure for that. And then we survey it with other ways. For people that do not have metastatic disease, whenever we do CT scans, for example, then oftentimes a colectomy or removing part of the colon is curative. A lot of what we talk about with staging of colon cancer, of course, the metastatic part is different. That means stage 4, and that treatment is not surgical. But for colon cancer that is localized, the stage really depends on the depth of invasion into the wall of the colon, as well as the lymph nodes that are around the colon. And so if the lymph nodes around the colon have cancer in them, whenever we take that section out, then we do usually recommend doing chemotherapy afterwards. And again, this is for colon cancer. Rectal cancer is a little bit more different and a little bit more complicated than colon cancer. But for colon cancer that has lymph nodes that are negative for cancer, we say that that person is usually a stage 1 or a stage 2, and we do consider them cured. everybody that has colon cancer is still at risk for colon cancer down the road. And so even though we consider these people cured, we still do things like CT scans every 6 months to a year, more frequent colonoscopies to make sure that it has not returned. And I do usually ask they follow up with an oncologist or a cancer doctor for that surveillance.
So we talked about the screenings, we talked about different kind of treatments. Are there any preventative measures that people can do to make sure that they are on the right track when it comes to colon cancer or colorectal cancer?
Yeah. So in general, we say that about half of polyps are due to some modifiable risk factors. What that really means is there are things that we can change, right? And most of it is completely common sense things. The colon is where the poop is. And so we suspect that a lot of times things like highly processed foods are related to things like colon cancers. We don't have great data for that yet. The things that we do have good data for are lots of things like processed meats, like deli meats, are not great for our colon and it can increase the risk of colon cancer. And then things like smoking, obesity, and lots of alcohol use are also a little bit high, make you a little bit higher risk for things like colon cancer. But I'm often, I think it is so tempting whenever someone has a diagnosis of colon cancer to think about the things that you could have done differently. But I'm here to tell you that a lot of healthy people can unfortunately get things like colon cancer, and oftentimes there is not a reason, it is random. And that's really scary to think about that there's not something that we can do in order to stop it. And that's why things like colon cancer or things like colon cancer screening with colonoscopy and advocating for yourself if you have things like blood in the stool or changes that you're worried about, paying attention to those symptoms is really important because sometimes it's not something that the person did. In fact, oftentimes it's not something that the person did. It's just bad luck.
So when some of these symptoms people might experience for other reasons, when is it an alarm that they need to go to see their doctor?
Yeah, so I think any rectal bleeding, I think I don't know about you, but I was always taught in by my teachers in middle school and high school that it's probably hemorrhoids. As crazy as it sounds, like it's just hemorrhoidal bleeding, right? And that is a complete fallacy. I can't tell you the number of patients that say, "Oh yeah, I have a little bleeding, but it's just hemorrhoids," who end up having something bad. And so making sure that you know that if you do have blood in the toilet, even if it's bright red blood, you need an exam by someone that knows what they're doing. Primary care doctor, a surgeon, a gastroenterologist, whoever, who can say, okay, yes, it looks like it's hemorrhoids, and let's treat it and see that it goes away. That's a really important piece of that because just blaming blood on hemorrhoids is a little bit scary. It's a little bit of a fallacy. Um, and then other symptoms that people have, you are so right. That thing like weight loss, changes in bowel habits, those things are super common for other reasons. But talking to your primary care doctor who knows you is really important to keep track of those symptoms and to see what they recommend. And certainly with certain conditions or family conditions, they may recommend screening for colon cancer earlier than the age of 45 based on your symptoms.
But the age to start screenings normally is 45.
45, yes, ma'am.
Okay.
We say that if you have a parent that has a diagnosis of colon cancer or another primary relative, so parent, sibling, child, you should start screening for colon cancers 10 years younger than they were at the age of diagnosis or at 40, whichever comes first. So if you have a father that had a colon cancer at 35, you should start screening yourself at 25.
For Colon Cancer Awareness Month, is there anything else that you want people to know? Any other bits of information you think would be helpful?
Um, I think just again, there is zero that you can say to embarrass your primary care doctor or your surgeon or your gastroenterologist. We have heard it all. And I think that so much of our care is dictated by us advocating for ourselves. And I just want to encourage people if you are worried or having symptoms, it is never wrong to talk to people about those symptoms. I see so many young people right now, and I'm sure you guys seen it all on the news. So many young people diagnosed with colon cancer, and I think that it's terrifying. And so the more people that are having symptoms we can get a colonoscopy, even though it's inconvenient and even though it's a little gross and a little icky, if we can get people to get screened and make sure that they're not having this problem, then I think we'll be able to really advocate for ourselves there.
Well, thank you so much for joining us. We really appreciate it.
It's my pleasure. Thank you so much for the opportunity. And yeah, I appreciate the chance to talk.